This is the cardiovascular screening examination. The major elements of this will include the observation, inspection, palpation, auscultation, and percussion. So we begin with observation and inspection, watching the chest wall rise and fall in a hopefully symmetrical pattern. We're going to look in the area of the heart to see if we can observe any extra pulse beats. This could indicate an enlarged part of the heart in that area. In some patients, but not all, we'll be able to observe an apical pulse, which is about at that fourth or fifth intercostal space at or inside that midclavicular line. This then leads us to observing for the internal jugular vein. The internal jugular vein lies overlying the sternocleidomastoid. Graham, could you look to the left side? So as I look in this area, I'm looking for 2 or 3 pulsations to differentiate the internal jugular vein from the carotid artery, which would be 1 pulsation. I could also take a light and flash it in that area to help me observe that internal jugular vein, which I may or may not see in all people. If I see external jugular distension, jugular venous distension, this could indicate an increase of central venous pressure in a patient. If I see that only unilaterally, that would indicate a kinking or a possible aneurysm. And to observe this, you want the patient in the position I have Graham at about a 30 to 45 degree angle. Graham, you can go ahead and put your neck straight, looking forward. Thank you. So this brings us into the palpation portion of the exam, which I'm going to try to warm my hands up. So for the palpation, I'm going to start with the carotid arteries. And this is located just lateral to the trachea. I'm going to want to do one side and then the other as I did. In this area, I'm feeling for the rate and rhythm of that pulse beat. It should be a strong beat with a brisk upstroke and a slower downstroke. If there is a reduction in that level of pulse beat, that could indicate reduced cardiac output in that patient. For a patient who's in a hyperkinetic state, you are likely to see an increase in that pulse beat. We then move to the apical pulse, which is going to be felt in about 1/2 of your adults, and it's going to be 1 to 2 centimeters. So apologize if my hand's cold, Graham. Try to feel for that. The apical pulse is going to be a gentle tap sensation. Then we move on to palpating for the abdominal aorta, which would be just left of the midline. And this would be located approximately in this area in the left upper abdominal quadrant. It should be 2.5 to 4 centimeters. If it's larger than that, that would be indicating an aneurysm. You're going to want to especially look for this in your elderly population who are partaking still in weightlifting and complaining of back pain or a pounding sensation in their abdomen. We then move to palpate the precordium along the left sternal border and the base. And here I'm just feeling for any abnormal pulsations. Next to discuss is the palpation of the liver, which I will not be performing, as you would want to palpate for this if you're considering your patient maybe has an enlarged liver. So you can palpate for feeling for the borders of the liver, which may be palpable if it is enlarged, such as with hepatomegaly or your patient with liver cirrhosis. This moves on to palpating for our peripheral pulse, which should be a 50 to 95 beats per minute. I will be grading the pulse from a 0 to 4 plus scale. 0, it's absent, 1 plus mild, 2 plus normal and easily palpable, 3 plus strong, and 4 plus is bounding and so strong that I would be unable to obliterate it. So I'm gonna just lift your wrist up here. So a normal area, or most common, is the radial pulse. I would listen for a full minute, and I would be comparing from side to side. Other pulses that I'll continue the peripheral pulses to assess. Some will do an ulnar pulse, extending the arm, listening or feeling for the brachial pulse. And relax your arm down. Grandma, I'm gonna be feeling in your hip groin area. Just let me know if it's tender. So between the ASIS and the pubic bone, just inferior to the inguinal ligament, I should feel for a femoral pulse. And then moving to the popliteal pulse in the popliteal fossa. And the popliteal pulse is going to be the most difficult to feel for, almost impossible. Your best attempt is to try to push that artery up against the bone. Then I'm going to just move this, turn the camera here so you can see the posterior tibial pulse, just inferior to the medial malleolus, and then the dorsal pedis pulse, just lateral to that extensor of the big toe. Then I also could assess for blood pressure. I do not have a blood pressure cuff, but to discuss what I would be looking for, the blood pressure normal range, systolic should be 100 to 120 beats millimeters of mercury, and the diastolic should be 60 to 80 millimeters of mercury. These are normal ranges which will vary based on a patient's age and individual factors. Yellow warning signs for a physical therapist with blood pressure is if you're comparing right to left and there's a greater difference than 10 millimeters of mercury systolic or diastolic. If your patient's systolic blood pressure raises 200 millimeters of mercury or greater, or diastolic 100 millimeters of mercury or greater during activity. And then if your patient's systolic blood pressure fails to rise with activity or actually falls during activity. For blood pressure, you're always going to want to compare right to left, perform in the same site, and with the patient in the same position, whether sitting or standing or supine. Then we assess for peripheral edema. So I'm going to press down in the pretibial area. And just raise your pants up. I would press down for 5 seconds and then see how quickly that tissue response is and how far of a pit my pressure produces. I will grade that on a 1 plus to 4 plus scale. 1 plus would be mild, 2 plus moderate, 3 plus deep pitting edema, and 4 plus very deep, and a very slow tissue response. With a 4 plus, you also would be able to observe for and see lower extremity swelling. This leads us to the auscultation portion. I'm going to turn the camera again. I'm going to start with the carotid arteries. Graham, can you take a breath in and hold it? And exhale. And hold your breath. And exhale. So with the carotid arteries, I'm listening for the hard sounds S1, S2 I may hear, but especially staying close attention to listening for bruits, which would be the sound from turbulent blood flow from a patient who has maybe an atherosclerosis. It's a blowing or swooshing sound. I then move on to the heart sounds. The areas I'll be looking at is that right second intercostal space of the aortic area. The left second intercostal space is the pulmonic area. Third intercostal space is Erb's point. Fifth is the tricuspid. Fifth, with the mid-clavicular line, is the mitral or apical pulse. And then just below the tip of the bottom of the sternum is the epigastric. With these sounds, I can perform them all using the diaphragm and also using the bell, listening closely to identify S1 and S2, extra heart sounds, or if there's a murmur. S1 is going to be that first pair of heart sounds that sounds like a lub dup. S1 is going to be louder than S2 at the apex. S2 will be louder than S1 at the base. S1 is a result of the atrioventricular valve closing, whereas S2 is due to the semilunar valves closing. Extra heart sounds, the most common is the mid-systolic, which sounds like a T-dup, which is due to that pulmonic valve closure. Other heart sounds that may be heard that are extra would be the S3 or the S4. They're going to be heard best in the apex area due to their low pitches. The S3 is a low pitch like a distant thunder, which is heard during the filling phase just before S3, and S4 is heard just before S1, is also a softer low pitch sound, which is heard due to a late closure or late contraction of the atria. That would conclude the auscultation portion. Lastly would be your percussion. You may want to percuss in the area of the chest wall to identify the left ventricular border of the chest. So you would hear a dullness, which would identify that border, not to be confused with lung dullness, which may be heard with an underlying condition. You also may want to percuss for the borders of the liver if you're concerned with an enlarged liver, starting at the second intercostal space. Moving down to about the fifth intercostal space is where you would start to hear that liver dullness, identifying that upper border of the liver. And that would conclude our cardiovascular screening exam.